Occlusal Scheme, RPD delivery, and post-treatment care. So after we do a framework try-in, then we were going to set up the teeth. So when we set up the teeth, first of all, we have to determine what's the occlusal scheme that we would likely to provide it. So in the complete dentures, you'll already be told that we have three different types of denture teeth. We have non-anatomic, like 0 degree. We have semi-anatomic, like 10, 20 degrees. We also have anatomy tooth, like 30 or 33 degrees. So how do we select it for our RPD patients? So when we have opposing tooths, then we will more likely to confirm those selection to an already established occlusal patterns. So the pattern presented at the time the removal part denture is made is dedicated to occlusion on the prosthesis. For example, if you see a patient have a flat tooth on the opposing side, you might want to select more likely like semi-anatomy or non-anatomy tooth to fit with the opposing tooth. However, if we don't have opposing tooth, then we might want to follow the complete entrance criteria for the posterior teeth selections. So it may depend on how the ridge form or how the patient's oral habits. For example, if patient have resorptive or flappy ridge, you may want to select more flat tooth, so to decrease the force to the ridge. Sometimes when patients have a previous dentures, then you might also want to follow that to create the similar occlusal scheme for the patients so they can get used to it immediately. So what kind of occlusal patterns we would like to set up for the patients? Is it canine guidance? Is it a full balance occlusions? Or it should be the good functions? So for RPD occlusions, the most likely we still want to keep the patient original occlusal plan or occlusal relationship. So the remaining teeth still dedicated to the occlusal scheme. Our job should be planned to have a contact in the centric relations and no interference in the lateral excursions. Means that once patient in the centric relations, the centric occlusions from the RPD to the opposing tooth should have a contact. However, when patient do a lateral movement, there shouldn't have any contact on the RPD because we don't want the RPD have a torquing forces to the tooth. However, sometimes you still have some exceptions. So we have two exceptions. We may need to have a walking contact or a balanced contact on the RPD teeth. The first is when the RPD is opposing to a complete dentures, or sometimes is when we have only anterior teeth remaining in both arch and the incisal relationship can be made. So the general rules is still to create the simultaneous bilateral contact of opposing posterior teeth in centric occlusions. When we have a tooth-supported RPD design, the occlusions can arrange similar to the occlusions be seen in the harmonious natural dentitions. Means that when patients have a tooth-supported RPD, we might want to create occlusions like the patient has before. When we set up artificial posterior teeth, it shouldn't be set up distal to ascending ramus or over the retrieval pad because we don't want to create the sliding of the RPD. So this concept is more similar like the complete dentures. So what if your RPD is opposing to a complete dentures? Then you still need to create bilateral balance occlusions. The reason is because the bilateral balance occlusions can promote the stability of the complete dentures. So this is not just considering your RPD design, this is also considering that opposing complete dentures. When we deal with the distal extensions RPD, then we might divide it by the mandible or maxillary, depends on the different scenario. So when we have mandibular distal extension dentures, then we were likely to have working side contact because they can distribute the stress over the greatest possible area. When we deal with the maxillary bilateral distal extensions, then we were more likely to have a simultaneous working and balanced contact. Means that we were more likely to have a full balance occlusions. Because we can minimize tipping of the maxillary RPD dentures and to broadly distribute the force to the supporting structures. However, when we deal with maxillary or mandibular just unilateral distal extensions like candy class 2 cases, then we were just only like the working contact to provide the support. In candy class 4 cases means that RPD teeth is opposing to the anterior natural teeth. Remember in the complete dentures we said we wouldn't like the artificial teeth in the interior have a contact because we want to prevent the denture tilting. But in RPD cases that we were likely to have a contact of opposing anterior teeth. The reason is we want to prevent the continuous eruptions of opposing natural incisors. However, if you have a lingual plate or some splintings, you can prevent those eruptions. You might not necessary to have anterior teeth contact. Also, we want that the contact of opposing anterior teeth in eccentric positions because it can create more incisive functions to give patients more abilities for the chewing functions. You also can permit balance occlusions without excursive interference. When we set up the posterior teeth on the RPDs, sometimes we might come into a scenario is that because patient lost a tooth for a long time, so a ridge is resulted. So when we have those situations, we might need to select a little bit smaller posterior teeth compared to the patient's natural dentitions because we want to decrease the stress distributed to the ridge. So you can see on these pictures that we have to select a little bit small, narrower buccal lingual width of a denture teeth to set up over a dentures area. Also, we might want to use a buccal shape to create the most posterior stress supported. So after that, you will send your setting to the lab and they will finish your RPD. So now that's the final step. We will deliver the RPD. So first of all, before you do a delivery, you have to do adjustment. When you do adjustments, then you should follow those sequence. First, you have to adjust the bearing surface of a denture base. The second is to adjust occlusion to accommodate the occlusal rest and the other metal part of the dentures. The final adjustment is to do the occlusions on the artificial dentitions. So how do we do adjustment to bearing surface of a denture base? So we should use pressure indicated test, which we likely to call PIV Pass in the clinic on integral surface. Sometimes when patients lost a tooth or has a xerostomia, their mucosa is very dry. It might affect the PIP pass indicators. So we were likely to rinse it before we sit the RPD over the mucosa so we can not stick to the soft tissues. Then we will use our fingers to provide some vertical and horizontal forces to be applied. Then we have to check that to see if we have any show-through spots. The most common questions comes out in the clinic is, so how do I know where I should remove? Should I remove all the show-through spots I saw in the integral surface of RPD? The answer is no. The decision to relieve those areas should be considered is the locations. If the location is on the primary supporting denture bearing area or the secondaries, you might able to keep it because the partial dentures still need to be resting over the tissues. It shouldn't be flow over the tissues. However, when the show-through spar is coming out on the non-supported denture bearing areas, then you should remove it all the way. So remember, those priming denture bearing areas is really follow the same principle as you've been told in the complete dentures. So you can see the sequence is to evaluate RPD, paint a thin layer of a PIV Pass, place the RPD, and then slightly grinding on the acrylic resins. The reason why I put these pictures in this slide is I would like you to see on the picture A that what we call the thin layer of a PIV Pass. When we said we should apply the PIV Pass in a thinner layer means that you should able to see the brush trace over the tissue surface. So you are easily to detect it where is the show-through spot. If you put too thicker, then you are not easier to observe, then the PIV Pass will not really provide the fully functions. When we do a border extension adjustment, when we deal with the tooth-borne RPD, this will be slightly different from the complete dentures because most of the support and stability is still provided by abutment tooth. So the denture base flange doesn't really need to extend it to a fully bordered. We just need to extend it to provide the positive soft tissue contact. Those positive soft tissue contact is try to prevent accumulations of a food underneath the denture base. However, when we deal with the tissue-borne RPD, then we still want to get the maximum tissue coverage, just like what we did in the complete dentures, because we still need to use those soft tissues to provide the good support and the stabilities. And we still need to avoid overextensions of the denture borders. After the adjustment of denture bearing area of RPD, then you will do occlusal adjustment. So first of all, we should do occlusal adjustment to remove occlusal interference from the denture framework. However, most of the time, we don't necessarily to do this step once we do a denture delivery because it should be solved before. So when do we do this? We actually do this when we do a framework triance. Because remember, when we do a framework triance, we not only to check the fitness of the framework to a natural dentition, we also need to see if the framework have any occlusal interference to the opposing natural teeth. If we saw those occlusal interference from the dental framework, we should adjust it once we do a framework triance. So most of the time, if you do the procedure correctly, you don't necessarily to do this in the denture delivery procedures. And remember that in the textbook it said for the dentist to have sent impression or a cast of a patient's mouth to a laboratory and to receive the finished removal partial dentures prosthesis without having tried the cast framework in the mouth is a dereliction of responsibilities to the patient and the profession. So you should always do a framework try-in and do adjustments before you move to the denture teeth setup and the finished RPD delivery. Then you have to do adjustment of occlusion to harmony with natural and artificial dentitions. So the most important thing is that we don't want to change patient's vertical dimensions. So the vertical dimensions with and without RPD should be the same. The ideal is to use a shin stock because shin strap is the thinnest appliance or the tools you can get from the clinic. You just have 8 micrometers thickness. That's the best tools you can check the patient's video with and without RPD. Then you will do occlusal adjustment. Most of the time, when we have a two-supported RPD, we may able to do adjustment intraorally. However, when we deal with the distal retention RPD, then we were more likely to use the articulator to do adjustments rather than to be adjusted in the intraoral. So how do we do adjustment on the articulator? So we have to do the clinical remounting. So the clinical remounting for distal retention cases, that means that we have to do a pickup impressions. The pickup impression means that you seat the RPD over a natural teeth. Then you use a tray with arginate to take impressions. When you finish the impressions, when you remove the tray with arginate, that those RPD will come out within your arginate impressions. That's what we call the pickup impressions. Then we have to book out those like clasp or proximal plate or any undercut we saw on RPD. Then we do the remount cast. So after we pour out the remount cast, then we position and mount it with the interocclusal record on the articulator. When you do interocclusal records, the most important is to be sure those records was made without the tooth contact. Because when you have a tooth contact for the interocclusal record, means that those positions records could be influenced by the tooth and can change the closure path and introduce the error. Because we should assume that you have some errors over your occlusal settings, then we will need to use articulator to do adjustment. So if you already have your artificial teeth contact with the opposing tooth, then definitely you might create some errors into your records. So very important is to ask patient to close but never over occlude it, so you will leave some space between the tooth to your partial dentures. You may ask, so how do we know that's accurate? Remember, when we do a removable prosthesis, we will likely to use the centric relations. So when the centric occlusions happen in the centric relations, means that those relationship is controlled by the centric relations. And which part control the centric relations? It's not by the tooth, it's by the condyle and disc relationship. So once you are able to get the centric relations, that even you have some space between the upper and the lower dentitions and the partial dentures, that relationship is still accurate. After you finish your remounting on the articulators, then you will start to do occlusal adjustments. Those occlusal adjustment principle is followed by the previous slide we talked about. The different occlusal scheme or the patterns were provided to the patients, followed by a different scenario. After you finish the RPD adjustments, means that now the RPD can be seated intraorally and have a good occlusal relationship to opposing tubes. Now you are ready to deliver the RPD to the patients. Patients need to be aware how to properly place and remove the RPD by themselves. Because if they couldn't properly place or remove the RPD by themselves, they either will distort your framework design, or they are not able to remove the RPD for a proper RPD clearance. When patients try to remove the RPD, they will more likely to use from the base, not directly from the clasp. because when they try to remove the RPD directly from the clasp, they might distort the clasp and eventually might cause the clasp broken. Patient also need to be notified. In the first beginning, they will have some discomfort or minor annoyance happens. They might have some phonetic change or the possibility of a gagging. So remember, patient already lost a tooth for a long time. They also go through a long treatment sequence from the beginning. So their tongue or their soft tissue already get used to without the tooth and without appliance. Right now, it seems like you put a new stuff in the mouth all the day. So they definitely will feel some minor discomfort. That's pretty common. You have to aware the patient because that's why we need to have a follow-up treatment. Patients also need to be aware the need to keep the denture and abutment tooth clean. They should clean after eating and before sleeping. For the RPD cleaners, they shouldn't use any household cleaners like hypochlorite and the toothpaste on the RPD surface because those hypochlorite may tarnish the crown cobalt framework, and the toothpaste has some abrasive material may hurt the smoothness of the denture base surface. So nowadays, we were more likely to use like a povidone tablet to create a solution. So we can soak those RPD into the solution for 15 minutes once daily. They already can remove most of the bacteria and the food debris over the RPD framework and the denture base. However, patients still need to use the toothbrush and the toothpaste to clean the natural dentition. So it's very important to remind them they have to brush the tooth, but not brush the RPD with the toothpaste. When they use a brush, they should select the small and soft bristle brush to prevent the soft tissue hurtings from the brush. Some patients may tell you they sometimes need to out of home to join the dinner with their family. It's too hard for them to clean the denture and the tooth when they away from home. So you just tell them the alternative way is to simply rinse the RPD and the mouth with the water after eating if they are not able to brush. You have to remind them that those rinse is just like you clean the dish. You don't want to use the dish over the past meal. So you definitely doesn't want you use RPDs over a meal. So patient always need to be reminded, no matter what, they should clean the RPD and the tooth after the meal. When they finish up the cleanings before they go to bed, those dentures should be placed into containers and covered with the water to prevent the dehydrations. Because when we left the RPD out of the water or out of the saliva, those dehydration may cause the microfractures over the denture base material, and those microfractures may create the unsmoothness of the denture base material. It also may create the dimension change of the denture base. So always remind the patients put the dentures into the waters before they go to the bed. And the water temperature should be just in the regular room temperatures. Never put into the hot waters because the higher temperatures also will create the distortions of the denture base material. In the school that we have our follow-up policies is that you should finish 24 hours, 1 week, and 1 month follow-up. When you do a follow-up, first of all, you have to ask patients how's the problems from the RPD, and then to do a thoroughly oral examinations. You have to check if patient have any mucosa irritations from the denture framework or the bases, and how is the patient ability to insert or remove the prosthesis. Also check if patient can clean their natural teeth well. If they have any mucosa irritations, that you have to adjust it with the PIV Pass. You also need to evaluate the retentive component, and if they lose the retentions, you have to do some adjustment. After that, you have to evaluate occlusions and articulations. You always remember when they started to use that, the denture teeth were started to worn out. So you may have a good occlusal relationship in the past, but after they started using that, those occlusal scheme may slightly change. So if you need, you also need to do some adjustment. And finally, try to finish and polish the dental framework and bases smoothly, so they will not easier to accumulate the food debris or the bacteria. After the 1 month follow-up, if there's no issues happens, patient might think their RPD treatment already finished. However, that's not the truth. They should have a periodic recall over life. The reason is we have to prevent or correct some errors might happen in the future. For example, it might happen to have a rocking and loosening in the futures because the supporting ridge resulted. Patients need to be notified that after they lose the tooth, that the remaining available ridge will keep resulted. So maybe the fitness of the RPD framework and the base to the tooth and the ridge may change in the future. If that really happens, then means that you have to do a reline or rebase to recreate the fitness from the denture base to the veal ridge. Also, the periodic recall can provide or ensure the health and longevity of the remaining oral structures, especially for natural dentitions. Some patients might ask you, so how often they should have periodic recall? The most common answer is 6 months. They also need to be notified that the clasp might get loose in the futures, and they might need to have some adjustment to recreate the retentions from the clasp. Because the RPD framework is made by metals, once they seated or removed from the mouth, they definitely were distorted by the tooth, followed by the several distortions that eventually those RPD framework might not really fit well as before. And then you should determine if you need to adjust it or remake a new framework. When you treated an upper complete denture, lower RPD cases, you should be very careful, because those cases is a common cause of the combination syndrome. If patient lost the follow-up and their denture base is not fitting well with the ridge, eventually they will become a combination syndrome patient and harder to deal with in the future. Patient also not to be provided any assurance for those crowned and uncrowned abutment tooths will not decay at some future times. Just remember why your patient need RPD: because they lose the tooth. Why they lose their abutment tooth? Because they not really care their tooth well in the past. So the RPD delivery doesn't mean that we already changed the patient's pattern of the dental care. So if patients still keep the original attitude or the way to take care of their tooth, they may still cause problems on existing dentitions. And it means that if patient lost more tooth, the RPD will not fit well as you expected. So always remember to remind the patient to have a periodic recall. And each periodic recall, you should not just only check the RPD, you also need to check if the patient can clean their tooth well. It means that your RPD can last longer.